Hi everyone, a wonderful and blessed day to all of you. Hoping that all of you are doing well and safe together with your families and loved ones. May God's guidance and protection be always with us as we continue to answer His call. So this week, we have again two topics, and this is the second topic for this week. The physical examination of the respiratory system. Before we proceed with our presentation, let me present to you this disclaimer slide. So these are the learning objectives of this presentation. At the end of the presentation, the student will be able to identify the structures and functions of the lungs, obtain accurate history of the respiratory system, identify the palpation, percussion, and auscultation sites for assessment of the lungs, correctly inspect, palpate, percuss, and auscultate the thorax. So before proceeding, let us have a review of the anatomy and physiology of the chest. So the chest findings are described in two dimensions along the vertical axis and around the circumference of the chest. For us to identify the vertical locations, we have to count the ribs and the sternal spaces. So we have to begin by finding the sternal angle, okay, also termed as the angle of Louis. For us to determine this angle, we have to place first your fingers in the hollow curve of the suprasternal notch, and then you can move your finger down approximately 5 centimeter, and then to the horizontal bony ridge joining the mandibulium of the body of the sternum. And then you can move your finger laterally and find the adjacent second rib. From here, you can use two fingers and then walk down the intercostal spaces, one space at a time. So on an oblique line. So it is easier to identify the intercostal spaces for women if you position the woman in a supine position. Okay, because this position will displace the breast tissue across the chest. Remember to avoid pressing too hard on a tender breast tissue. Okay. The costal cartilages of the first 7 ribs articulate with the sternum. The cartilages of the 8th and the 9th and 10th ribs articulate with the costal cartilages just above them. The 11th and the 12th ribs has no attachment, so the cartilaginous tip of the 11th rib usually can be felt laterally, while the 12th rib may be felt posteriorly. Posteriorly, the 12th rib is another possible starting point for counting the ribs and the intercostal spaces. So it helps you to locate the findings on the lower posterior chest and provides an option when the anterior approach is unsatisfactory. So with the fingers of the one hand, press in and up against the lower border of the 12th rib, and then walk up the intercostal spaces numbered in red. Okay? So, yan yung mga intercostal spaces. To locate findings around the circumference of the chest, we usually use a series of vertical lines that is shown in this image. So the mid-sternal line and the vertebral lines are easily seen. No? By just looking at your patient, you can imagine the mid-sternal and the vertical lines. So the others are just estimated. For the mid-clavicular line, so it drops vertically from the midpoint of the clavicle. And for you to accurately locate this one, you need to identify both ends of the clavicle and then find the center and then drop. Okay, so the anterior and the posterior axillary folds, okay, or the posterior and the anterior axillary lines drops vertically from the anterior and the posterior axillary folds, which are the muscle mass that border the axilla. Okay, the mid-axillary line drops from the apex of the axilla. Okay. So posteriorly, the vertical line overlies the spinous processes of the vertebra. So the scapular line drops from the inferior angle of the scapula. So aside from using those vertical lines to describe our findings, we also have to use the following exterior landmark picture of the lungs and their fissures and lobes on the chest. Anteriorly, the apex of each lung rises approximately 2 to 4 cm above the inner third of the clavicle. The lower border of the lung crosses the 6th rib at the mid-clavicular line and the 8th rib at the mid-axillary line. Posteriorly, the lower border of the lung lies at about the level of the T10 spinous process. On inspiration, it descends further. So each lung is divided roughly in half by an oblique or major fissures. So this fissure may be approximated by a string that runs from the T3 spinous process obliquely down and around the chest to the 6th rib at the mid-clavicular line. The right lung is further divided by the horizontal minor fissure. So anteriorly, this fissure runs close to the 4th rib and it meets the oblique fissure in the mid-axillary line near the 5th rib. Here. So the right lung is thus divided into right upper lobe, right middle lobe, and right lower lobes. So on the other hand, the left lung has only 2 lobes. We have the left upper lobe and the left lower lobe. So it is important for you to learn the anatomic terms used to locate the chest findings for you to be able to describe it correctly. So another part or structure of our respiratory system, we have here the trachea. So the major bronchi breath sounds over the trachea and the bronchi have a harsher quality than the breath sounds over the lung parenchyma. It is important for you to know the location of these structures because you will be describing your findings later, especially for the breath sounds, whether there is adventitious sounds. Okay. The trachea bifurcates into its main stem, bronchi, at the levels of the sternal angle anteriorly and T4 spinous process posteriorly. So the right main bronchus is shorter and wider and more vertical than the left main bronchus, which extends more laterally. Okay, moving on to the mechanisms of breathing. So we know that breathing is largely automatic. Okay, so it is controlled by the respiratory center in the brain, known as the brain stem, and it is mediated by the muscles of respiration. So the diaphragm is the primary muscle of inspiration. So when it contracts during inhalation, it descends in the chest and it enlarges the thorax cavity or thoracic cavity. Okay, at the same time, it compresses the abdominal contents, pushing the abdominal wall outward. So, kaya nakikita rin natin yan sometimes hindi observable sa tiyan natin tinitingnan. So, the muscle or kinakount yung respiration. The muscles in the rib cage and the neck also expand. So, during inspiration, as these muscles contract, the thorax expands, intrathoracic pressure decreases, drawing the air through the tracheobronchial tree into the alveoli or distal air sacs, and it expands the lungs. So the oxygen diffuses into the blood of the adjacent pulmonary capillaries, and then carbon dioxide diffuses from the blood into the alveoli. So after inspiration, okay, the expiratory phase again begins. So during expiration, so the chest wall and the lungs recoil. So the diaphragm relaxes and rises passively. So the air flows outward and the chest and the abdomen return to the resting position. So makikita natin na naka-rest na ulit. So you have to take note that normal breathing is quiet and easy. So it is barely audible near the open mouth as a faint wheeze. During exercise and in certain diseases or conditions wherein extra work is required to breathe, so the following muscles or accessory muscle join in the inspiratory effort. So those are the sternocleidomastoids here. Okay, we have the ischials and the abdominal muscle. So these muscles become visible no, kapag merong labored breathing. So because it assists the following muscles assist in expirations. Moving on to the health history. So you have to take note of the following common concerning symptoms. You have to check if there is shortness of breath or termed as dyspnea. Okay. So you have to check for the onset, kung meron man, no? When did you first feel the short of breath? For example, did you or did anything bring on the shortness of breath? Example, meron ka bang exposure to any allergen, may nakain na gamot or inainom na gamot or nakain food na allergy ka. So, for the location is the difficulty in your throat or neck area or chest. Okay, for the duration, you can ask the client, does this occur at a particular time of the day? Okay, for how long? Yan. Is the shortness of breath worse when you are lying down or upright? For the associated factors. Okay. Does anything make it better? for the relieving factors. No treatment. Have you seen anyone or have you tried to consult a doctor or physician, or did you take any medications or treatment? Okay, note also for the following: wheezing, cough, blood-streak sputum or hemoptysis, purulent sputum, or chest pain. For the overview of your health history, you have to include the following: respiratory problem, cardiac problem, gastrointestinal problem, musculoskeletal problem, because all of this, or of all of the system, they are allocated closely and may have, or the manifestation may have related with each other. Okay, so for the initial questioning, example, it should be, of course, broad. So if there is, for example, complaint of dyspnea, you have to check the following: sudden onset, okay, may indicate anaphylaxis or pulmonary embolism, spontaneous pneumothorax, anxiety. And you can also see this in your book. Okay, so you have to be very careful kung merong shortness of breath, that baka biglang mawala na talaga ng breathing si patient because of anaphylaxis. So, kailangan, this is life-threatening. Okay, if there is wheezes, there might be a partial airway obstruction or tissue inflammation, or there could be a foreign body. So this is usually found in patients with asthma. So when we see wheezes, these are musical respiratory sounds that may be audible to the patient and others. So wheezes, again, are caused by partial obstruction of the lower airways, wherein the airway may be narrowed due to bronchoconstriction or edema, secretions, especially for those clients again with asthma. So another findings during your health history taking could be cough. So cough is typically a reflex response to a stimuli that irritate the receptors in the larynx, the trachea, or the large bronchi. So these stimuli include mucus, could be pus, blood, dust, foreign bodies, and even extremely hot or cold air. So coughing may also be caused by inflammation of the respiratory mucosa or the tension in the air passages from tumor or enlarged peribronchial lymph nodes. Okay. So cough may be related to a left-sided heart failure, upper respiratory infection, bronchitis, and pneumonia. You have to take note for the sputum. Is it mucoid, purulent, foul-smelling, and you have to check the amount of mucus. So for acute cough, these are usually less than 3 weeks. For subacute, 3 to 8 weeks, and for chronic, it's more than 8 weeks. You can also check your book on table 13 to 2 of the respiratory system chapter. So another finding could be chest pain. Okay. So chest pain may be caused by cardiac, could be respiratory, gastrointestinal, or musculoskeletal etiologies. So kaya importante din you have to take note of this. So it could be pericarditis, angina pectoris, or there is myocardial infarction, or this dissecting aortic aneurysm kung yung cause ng chest pain is the cardiac. But if the cause of the chest pain is the respiratory, there could be bronchitis or pneumonia. For more examples, you can see your table 13.3. So again, if you have findings of chest pain, so with the same with the other findings, you can again use your old card mnemonic. Of course, that is for you to identify the source of the pain. So if the cause of the chest pain is gastrointestinal, there could be a problem with reflux esophagitis, esophageal spasm, gastritis, or biliary colic. So if the cause of the chest pain is musculoskeletal, it could be due to cervical arthritis, costochondritis, herpes zoster. Or if the cause is anxiety, so of course, if it is anxiety, it is psychological, the mechanism is unknown. So moving on to the past history. So you can ask your client if there is any prior problems, surgeries, allergies, TB skin testing results. Okay, if there is TB skin testing, chest X-ray. Okay, does the patient underwent influenza and immunization, pneumococcal or varicella zoster immunization, traveled outside the United States? That could be have possible, lalo na ditong time natin, COVID. So, halimbawa, nung unang lumabas ng COVID, diba, sa China. So, kung travel ka ba ng China? So, mga ganong scenario. Okay, for the family history, you can check for the current respiratory infection or disease. Like for example, meron bang may COVID sa family or may exposure ba sa COVID patient? Okay, lung cancer, asthma, cystic fibrosis, and tobacco use. For the lifestyle and personal habits, you can check for the following: tobacco products, or is the patient a smoker, recreational drugs, exposure to secondhand smoke, exposure to environmental hazards, or prescription of over-the-counter drugs and any nutritional supplements, the use of oxygen, nebulizers, and the like for breathing difficulties. So, let's move on to the physical examination. So, as an overview, you have to position your client on sitting position with arms across the chest, hands on the shoulder, and then you can start examining the posterior thorax and the lungs. With the patient in supine position, you can examine the anterior thorax and the lungs. If the patient is unable to sit up, you can roll the patient to one side and then the other, and then you can start examining the dependent lung on each side. So for the initial survey of respiration in the thorax, you have to note the following. Okay, for the respiration, the rate, the rhythm, the depth, and the effort of breathing. May difficulty ba? Labored breathing? Right, easy lang naman yung breathing niya. So, yung rhythm, yung rate, ilan ba siya? Within the normal range. Okay, the facial expression, the level of consciousness, and then you have to assess the patient's color. Baka meron na bluish or meron tayong cyanotic patient. Assess for or listens to the patient's breathing if there is a presence of wheezing. Okay, inspect the neck kung ginagamit na ba yung mga accessory muscles natin, the sternocleidoid muscles. Observe the shape of the chest. May barrel chest ba? So this is the normal pattern of normal respiration. Okay, inspiration and expiration. The normal respiratory rate is about 14 to 20 per minute in normal adults and up to 44 minutes in infants. So depends to your references. So other references would say the normal breathing for adults is 12 to 20. Others would say that the normal breathing for infant is up to 60. Okay, so breathing is punctuated by frequent signs suggest hyperventilation syndrome, which is a common cause of dyspnea or shortness of breath and dizziness. So occasional sighs are normal. So this is another pattern of sighs or sighing respiration, which is a type of a long and deep breath. So it usually begins with a normal breath, okay, and then you take a second breath before you exhale. So we often associate sighs with feelings such as relief, sadness, and exhaustion. So this is another image or pattern of respiration. So we have bradypnea or slow breathing. So it could be with or without an increase in tidal volume that maintains alveolar ventilation. So abnormal alveolar hypoventilation without increased tidal volume can arise from uremia or from drug-induced respiratory depression and increased intracranial pressure. So this is when you are breathing more slowly than normal. So this could sometimes mean that your body isn't getting enough oxygen. So bradypnea can also be a sign of a condition that affects the metabolism, or it could be from another problem like sleep apnea, carbon monoxide poisoning, and drug overdose. So another pattern here is the tachypnea or rapid shallow breathing. So kita nyo pag mabilis but shallow. So it has numerous causes that include salicylate intoxication, could be restrictive lung disease, pleuritic chest pain, and an elevated diaphragm. So another abnormalities in the rate and rhythm is we have here the Chinis-Stokes breathing, wherein the periods of deep breathing alternate with periods of apnea. So as you can see here, wherein there is no breathing happens. So this pattern is normal in children and in older adults during sleep. The usual causes includes heart failure, uremia, drug-induced respiratory depression, and brain injury. So another here is obstructive breathing. So during obstruction in the lung disease, expiration is prolonged. Okay, there is prolonged expiration due to narrowed airways that increase the resistance to airflow. Causes includes asthma, chronic bronchitis, and chronic obstructive pulmonary disease. So another here is hyperpnea, or there is a rapid deep breathing or Another term is hyperventilation. So in hyperpnea or rapid deep breathing, usually occurs in response to metabolic demand from causes such as exercise or high altitude, sepsis, and even in patients with anemia. So in hyperventilation, this pattern is independent of metabolic demand except in respiratory acidosis. So another abnormality is the biot breathing or the ataxic breathing. The breathing here is irregular. Okay, there is periods of apnea alternate with regular deep breaths, which stop suddenly for short intervals. The causes includes meningitis, respiratory depression, brain injury, typically at the medullary level. So let us now proceed to the physical examination of the posterior chest. First, you have to utilize your 4 cardinal techniques in doing the physical examination of the respiratory system, and you have to begin with inspection. So you have to take note for the shape and the movement of the chest. Okay, of course, movement this refers to the breathing pattern of the client, no? If the client is breathing normally or there is difficulty of breathing. So check for any deformities. For example, there is a pigeon shape of the chest. There is abnormal retractions of the intercostal spaces, or is there impaired respiratory movement. So, upon inspection, you may find the following findings. Okay, we have here the normal adult, the shape, the configuration of the chest. Okay, and then we have another image here, the normal adult funnel chest, or what we call pectus excavatum. So the thorax in the normal adult is usually wider than it is deep. So its lateral diameter is larger than its anterior posterior diameter. Okay. So for the funnel chest or the pectus excavatum, you can note the depression. Okay, so the depression in the lower portion of the sternum. So compression of the heart and great vessels may cause murmurs upon auscultation. So another deformities here is what we call the barrel chest, wherein there is an increase anterior posterior diameter. So this shape is normal during infancy and usually accompanies aging and chronic obstructive pulmonary disease for the adult. So another abnormalities or deformities of the thorax here is the pigeon chest, or what we call the pectus carinatum. So wherein the sternum is displaced anteriorly, increasing the anterior posterior or anteroposterior diameter. So the costal cartilages adjacent to the protruding sternum is depressed here. And this is the anteriorly displaced sternum. Okay, so another deformities of the chest, we have here a traumatic flail chest. So the multiple rib fractures may result in paradoxical movements of the thorax. So as the descent of the diaphragm decreases intrathoracic pressure, during inspiration, the injured area caves in or caves inward, During expiration, it moves outward. So we have another here, the thoracic kyphoscoliosis, wherein there is an abnormal spinal curvatures and the vertebral rotation that deforms the chest. Okay. So distortion of the underlying lungs may make interpretation of the lung findings difficult. Okay, so moving on to the examination of the posterior chest. So again, we have to start with inspection. So nasa inspection pa lang tayo na anterior and then the posterior chest. So note for deformities or asymmetry, like mentioned in the previous slides, if there is scoliosis, kyphosis, etc. So intercostal retractions during inspiration, impaired respiratory movement of one side or both sides, or a unilateral lag or delay in movement. Okay. So after inspection, we can now proceed to palpation. So you can palpate the areas and check for tenderness. Is there abnormalities? Also check for the chest expansion. So I will discuss this further in the next slides. Tactile fremitus, and then compare asymmetric areas. So these are just the pattern of how you will palpate. No? One, you can use your both pads of your fingers from the index, the middle, and then the fourth finger. Okay, you have to place it here and then move to number 2, number 3, and the number 4. So you have to identify for the tender areas by gently palpating these areas. Okay. So you also have to observe for abnormalities like masses, as mentioned in the previous slides. And for the chest expansion, you have to place your thumbs at about the level of the 10th ribs with your fingers loosely grasping and parallel to the lateral rib cage. As you position your hands in this image, slide them medially just enough to raise a loose folds of the skin on each side between your thumbs and the spine. And then, you can ask the client to inhale deeply, hinga pong malalim, and then watch the distance between your thumbs as they move apart during inspiration. And you also have to feel for the range and the symmetry of the rib cage as it expands and contracts. So you have to remember that the normal finding is that your thumbs should move equally apart. Diba? Meron tayo dito vertebral line. So dapat equally apart. The causes of unilateral decrease or delay in the chest expansion includes a pleural effusion, lobar pneumonia, pleural pain, and associated splinting or unilateral bronchial obstruction. Or it could be a chronic fibrosis of the underlying lung or pleura. So this is how you will feel for the tactile fremitus. So I will post a video of what you can hear for the fremitus. So fremitus refers to the palpable vibration transmitted through the bronchopulmonary tree from the trachea down to the parenchyma, the chest wall as the patient is speaking. So for you to detect a fremitus, you have to use either the ball or the bony part of the palm at the base of the fingers, okay, or the ulnar surface of your hand to That is to optimize the vibratory sensitivity of the bones in your hands. And then you can ask the patient to repeat the words na sasabihin mo. Okay, so yung movement then, so katulad din ito. You have to start both hands from 1, then 2, 3, and then 4. That is how you will move your hands, whether you are using the ball of your hands or your ulnar. And then you can, as you move your hands, for example, you're putting your hands on these numbers, you can say, ask the patient to repeat after me 1, or 99, 99, okay. If the fremitus is faint, ask the patient to speak more loudly or in deeper voice. The simultaneous use of your both hands, of course, sabay siya dito. That is for you to compare the sides. And then you can increase your speed and may facilitate detection of the asymmetry. So, hindi sobrang bagal. Okay? As you put your hands, two hands, left and the right ulnar here, you ask the client to say 99, then move 99, 99, move. Okay. So moving on to the third cardinal technique of physical examination, we have percussion. So this helps to establish whether the underlying tissues are air-filled, fluid-filled, or solid. So it penetrates only at least 5 to 7 cm into the chest. So the technique of percussion can be practiced on any surface of the body. So the key points for good technique is to describe for a right-handed person as is illustrated in this image. So you have to hyperextend the middle finger of your left hand, known as the pleximeter. Okay, so and then press its distal interphalangeal joint firmly on the surface to be discussed. Okay. Avoid contact by any other part of the hand because this dampens out vibration. Note that the thumb of the second, fourth, and your fifth fingers are not touching the chest. Okay, so only the middle finger. And then you can position your right forearm quite close to the surface with the hand cocked upward. So the middle finger should be partially flexed, relaxed, and poised to strike. Okay? With a quick, sharp, but relaxed wrist motion, strike the pleximeter finger with the right middle finger or your flexor finger. So aim at your distal interphalangeal joint. You are trying to transmit vibrations through the bones of the joint to the underlying chest wall. So when you strike, use the tip of the flexor finger only, not the finger pads. So your finger should be almost at the right angles of the pleximeter. So you should have a short fingernails to avoid self-injury. So to summarize, the movement is at the wrist. It is directed wrist, yet relaxed and slightly bouncy. So these are another illustrations of the pattern. So you can also use this pattern in doing palpation, percussion, and auscultation. So other references would use this pattern para mas closer yung ating findings, no? Areas of the lungs para ma-include yung ating apex of the lungs, middle lobe of the lungs, okay, lalo na yung right and left, no, na merong sa right merong 3 lobes, okay. So these are the findings, okay, percussion notes and their characteristics. So that is for you to differentiate kung ano yung sound, okay, the relative intensity, relative pitch, relative duration, and example of location. For example, no, if you are percussing the lungs, okay? So here, this is an example, no, resonance. So relative intensity should be loud, relative pitch low. So the relative duration is long. This is an example sounds of or tone rather of the healthy lungs. Okay, there could be some pathologic examples. For simple chronic bronchitis, also meron din siyang resonance sounds. Okay, to continue with our percussion. Okay, so aside from percussing for the tone, you have also to percuss for diaphragmatic excursion. So while the patient keeps both arms across in front of the chest, you have to percuss the thorax in symmetric locations from the apex to the base of the lungs. So alternate percussing one side of the chest and then on the other at each level in a ladder-like pattern. Okay, so as shown in the photograph below or here. So you have to begin above the scapula, okay, and then so on. So na-discuss na natin yan. So to identify for the diaphragmatic excursion, okay, first you have to determine the level of diaphragmatic dullness during quiet respiration. And then again, using your percussion technique, you have to percuss downward in progressive steps until dullness clearly replaces resonance. Okay, so note that with this technique, you are identifying the boundary between the resonant lung tissue and the duller structures below the diaphragm. So you are not percussing the diaphragm itself. So you can infer the probable location of the diaphragm from the level of dullness. And now you can estimate the extent of diaphragmatic excursion by determining the distance between the level of dullness on full expiration and level of dullness in full expiration. So normally, it's between 3 to 5 cm. So during the procedure, you have to ask the patient to breathe in and then out fully and then hold his breath. So inhale, exhale, hold, and then you can start percussing down to dullness. And then you should have your marker pen and then you can mark this point on the patient's back with, again, your marker. So, and then you can ask the client to breathe in. May mark ka na dyan. Okay, may mark ka na to breathe in again. And then, in full, so inhale, and then hold our breath. And then continue percussing down until dullness mark its point. Okay, so, and then, repeat on the opposite side. So, ito yung may dullness na. Okay, then measure the distance. Okay, it should be equal through the right side. So, dapat pareho lang yung kanilang distance. 1 cm is okay due to liver, no? The diaphragmatic excursion should be again 3 to 5 cm in adults. But for athletics, okay na sa kanila yung 7 to 8 cm. Okay, so for you to understand better about how to do this, it is also in my physical examination 2 video of how to perform or how to assess the tone for diaphragmatic excursion. So now, after doing the inspection, palpation, and percussion, and then let's now move on to auscultation, which is the most important examination technique for assessing airflow through the tracheobronchial tree. Of course, together with percussion, it helps the nurse to assess the condition of the surrounding lungs and the pleural space. So listens, in doing your auscultation, you have to listen to the sounds generated by breathing. So listens for any adventitious sounds like wheezes, bronchi, stridor, and etc. Listens to sounds of spoken words through chest wall if any abnormality is suspected. Okay, so this image shows a picture of normal air-filled lung and the airless lung as in lobar pneumonia. So here, the original of breath sounds are actually unclear. So the turbulent airflow in the pharynx, glottis, and the subglottic region produces the tracheal breath sounds, which are similar to bronchial sounds. So the breath sounds predominantly in the vesicular area. So the inspiratory component of vesicular breath sound seems to arise in the lobar and segmental airways. The expiratory component arises in the more central larger airways during expiration. Okay, so normally, tracheal and bronchial sounds may be heard over the trachea and main bronchi. So the vesicular sounds predominate throughout most of the lungs. So the transmitted voice sounds, spoken words muffled and indistinct spoken like E, heard as E. So whisper words faint and indistinct if it is heard at all. So usually the tactile fremitus here is normal. On the other hand, for the airless lung, okay, during kapag may pneumonia, so the bronchial or bronchovesicular sounds over the involved area is greater. No spoken words here is louder and clearer. Or there is bronchophony, or spoken E heard as I, or egophony, whisper words louder or clearer. Or you can also use your whispered pectoriloquy. So, for the airless lungs, the tactile fremitus is increased. Because the fluids and the solids transmit the sounds and vibration waves better than air. So when lung tissue loses its air, so it transmits a high-pitched sound much better. Okay, these are just another illustration of the breath sounds, no? An examination of the posterior chest. So for the vesicular sound, so the duration of sounds, inspiratory sounds last longer than expiratory. So I is greater than E. So for the vesicular sounds, it is soft and relatively low. It is heard over most of both lungs. For bronchovesicular, inspiratory and expiratory sounds are about equal. So the intensity of expiratory sound is intermediate. Pitch of the expiratory sound is intermediate as well. It is often in the first and second intercostal space, anteriorly and between the scapula. For bronchial sounds, so expiratory sounds last longer naman than expiratory sounds. So, intensity of expiratory sounds is loud, relatively high yung kanyang pitch, and it is heard over the manubrium or it is heard at all. Okay, for the tracheal, inspiratory and expiratory sounds are equal. So, halos pareho sila ng broncho, vesicular, and your tracheal. But the intensity of expiratory sounds is very loud. So relatively high, and it is heard over the trachea in the neck. So let's move on to abnormalities or adventitious or extra lung sounds. Okay, you have to listen for adventitious sounds or extra lung sounds during your auscultation. Okay, so detection of adventitious sounds like crackles, that we sometimes call as wails, wheezes, and bronchi, is very important part of your examination, because often leading to diagnosis of cardiac and pulmonary conditions. The most common kinds of these sounds are described in this table. So we have here crackles versus wheezes and bronchi. So it is discontinuous while wheezes is continuous. Okay, it is intermittent, non-musical, and crackles in brief. It is like dots in time, and it has two kinds. We have fine crackles and coarse crackles. Fine crackles are soft, high-pitched, very brief, that lasts for 5 to 10 milliseconds. However, the coarse crackles somewhat louder, lower in pitch. It is brief, 20 to 30 milliseconds. For the wheezes and bronchi, it is continuous again, and it lasts equal or more than 250 milliseconds. It is sinusoidal prolonged, but not necessarily persisting throughout the respiratory cycle. So it is like dashes in time. So it is musical, relatively high pitch, with more or less 400 hertz, with hissing or shrill quality. So bronchi, relative low pitch, okay, less than or equal to 200 hertz, with snoring quality. So let's now proceed to the examination of the posterior chest. Findings of adventitious sounds. Okay, so this is an image of crackles. So again, crackles, okay, this usually appears during inspiration, nawawala during expiration. So again, crackles are discontinued non-musical sounds that can be early inspiratory, as in those patients suffering with COPD or chronic obstructive pulmonary disease. So in late inspiratory, it is in those patients with pulmonary fibrosis. So fine crackles are soft, high-pitched, and more frequent per breath than coarse crackles. So we have here wheezes. Wheezes and bronchi are again continuous musical sounds that occur during a rapid airflow when the bronchial airways are normal. Okay. Okay, so another adventitious sounds or findings of your posterior chest. We have here the stridor, which is a continuous high-frequency, high-pitched musical sound that is produced during airflow through a narrowing in the upper respiratory tract. So it is best heard over the neck during inspiration, but again can be biphasic. So the causes of the underlying airway obstruction include tracheal stenosis from intubation, airway edema from device removal during removal of the tracheostomy, croup epiglottitis or foreign body, and anaphylaxis. Therefore, if there is a problem, for example, anaphylaxis, intermediate intervention is necessary. So, another example here is we have the pleural friction rub, okay, which is a discontinuous low-frequency grating sound that arises from inflammation and roughing of the visceral flora as it slides against the parietal flora. So this non-musical sound is biphasic. It is heard during inspiration and expiration. It is often described as creaking or like two pieces of leather rubbing together. So it is often best heard in the axilla and the base of the lungs. So this video is from the YouTube. Okay, this is just an example of breath sounds.
Hi everyone, this is Ryan from rpnt.ca, and today we're going to be learning about different breathing patterns. Here is a quick overview of the breathing patterns that we'll cover, with a visualization and example respiration rate for each one. You can use the timestamps in the video description to jump ahead. First, we'll start with the normal or regular breathing pattern, also known as eupnea. Here, you can see how a normal breathing pattern is usually visualized. It kind of looks like a nice and steady wave. This is because eupnea is unlabored and has a nice and steady rate, meaning it remains regular and consistent. As you breathe in, the line moves up, and as you breathe out, the line moves down. So again, eupnea is nice and regular inspiration and expiration, which occurs at rest, and a general baseline respiration is about 12 to 20 breaths per minute. Keeping eupnea here for reference, we'll move on to tachypnea. Tachypnea, or rapid breathing, looks very similar to normal breathing, but as you can see, the inspirations and expirations occur much faster. So with tachypnea, you get more breaths per minute. Tachypnea can be caused by so many different problems, including asthma, anxiety, pneumonia, and so much more. Bradypnea, or slowed breathing, is simply the opposite of tachypnea. You can see that the inspirations and expirations are more spread out. They occur over a longer period of time. So with bradypnea, you see fewer breaths per minute. Bradypnea can be caused by many different things as well, including opioid administration, cardiovascular problems, and much more. Apnea is the absence of breathing. You can see here that during apnea, there are no inspirations or expirations. Apnea can be temporary, like during sleep apnea, or permanent following a head injury or stroke. Hyperpnea is breathing in more air than normal. You can think of this as taking deeper breaths. This is represented by a taller wave. Do note that hyperpnea doesn't necessarily mean the respiration rate is increasing. Again, it's deeper breaths rather than faster breaths. However, in some cases, you can have both hyperpnea and tachypnea at the same time. Hyperpnea may be caused by exercise, anemia, high altitudes, and more. Hypopnea is simply the opposite of hyperpnea. It is breathing in less air than normal, which is represented by smaller waves. You can think of hypopnea as taking shallow breaths. There are many causes of hypopnea, some of which include neuromuscular disease, sedatives, obesity, and more. Cheyne-Stokes breathing is a gradual change between hypopnea and hyperpnea, followed by a period of apnea, and this pattern repeats. In other words, the Cheyne-Stokes pattern is the change between a gradual increase and gradual decrease in the deepness of each breath, followed by a period of no breathing. Cheyne-Stokes breathing may occur in various brain injuries, including increased intracranial pressure, stroke, and more. Cheyne-Stokes breathing may also occur in heart failure and those near end of life. Biot's breathing is characterized by a period of hyperpnea, followed by a period of apnea, and this pattern repeats. Biot's breathing differs from Cheyne-Stokes breathing because there is no gradual increase or decrease in the pattern. Biot's breathing may occur in stroke, CNS trauma, meningitis, and more. Kussmaul's breathing is a type of hyperventilation, and it is the combination of tachypnea and hyperpnea. This means a rapid respiration rate with deep breaths. Kussmaul's breathing can occur in diabetic ketoacidosis, or DKA, and metabolic acidosis. The rapid, deep respirations help to expel more ketones and carbon dioxide, decreasing the acidity of the blood. And that's about it for these breathing patterns. If you have any questions, please let me know in the comments or visit rpnt.ca for more help.
Okay, so to continue with our examination of the posterior chest, okay, you have to remember to check the fremitus, okay, the transmitted voice sounds. So increased transmission of voice sounds suggests again air-filled lung has become airless. Okay, you can ask the patient to say 99 E, okay, or whisper 99 or 1, 2, 3. So again, as a review of the examination of the anterior chest for inspection, you have to check for the shape or configuration, work of breathing, is it easy or unlabored, local lag or impairment, or is there bruising or skin lesions. Okay. For the palpation, you have to identify if there is tender areas, assessment of your observed abnormalities, and do further assessment of the chest expansion and assess for tactile femtools. This is just a review. Okay. So again, for the palpation, you can, and this is an example of how you will do the palpation. This is for checking the chest expansion and then following this pattern. So for percussion, so you will utilize this pattern, okay, in zigzag. Okay, by the zigzag, you have to percuss one, then next one again, 2, 2, 3, and then so on. So this is how you properly position your hands or your fingers. So this is for the percussion of the tone of the between the lungs and the liver. Okay, so moving on to special techniques. No, we have here the pulse oximetry. Okay, this measures the arterial oxygenation saturation, or this is what we call SpO2, wherein a probe is placed on the patient's finger or earlobe. So sometimes the toe is used for infants and young children, wherein a diode emits light and a detector on the opposite side of the probe measures the amount of the light absorbed by the oxyhemoglobin. So the oximeter compares the amount of the light emitted to the amount absorbed and calculates the percentage of the oxygen saturation. So the healthy person has 95% to 100%. Okay, for poor perfusion, hypotension, dyshemoglobinemias or dyes in some nail polish, and excessive ambient light may cause inaccurate readings. So we also have here another special technique, no? Wherein you can use a peak flow meter or peak flow assessment to assess the maximum volume of air expelled from the lungs during a vigorous exhalation. So a decrease in peak flow volume occurs in diseases that reduce outflow of the air, for example, those patients who have asthma. So a peak flow decreases the severity of an exacerbation increases. So regular monitoring of a patient's peak flow can evaluate the effectiveness of the treatment, particularly for those who have chronic asthma. So as part of your special technique is to identify if there is any fracture rib. Check for local pain and tenderness. Alright, so after doing the health history and the physical examination, it's now time for you to report your findings accurately. Do not forget to include the following: the shape of the ribs, the sounds or the breath sounds, the effort, is it easy or is there labored breathing, the fremitus, tactile fremitus, the abnormalities, and then you can see other findings on your table 13-8 of your book. So for health promotion and counseling, okay, so of course we have to encourage the client to stop smoking or tobacco cessation. You have to explain that tobacco is or the advantage or the disadvantages of using tobacco that is linked to cancer, emphysema, infertility, preterm birth, low birth weight, sudden infant death syndromes, asthma, diabetes, cataracts, and rheumatoid arthritis. So again, part of your health promotion is to explain the adverse effects of the smoking on health and diseases. These are the conditions and the increased risk compared with non-smoking. For example, for those who have COPD mortality, okay, so the increased risk compared with non-smoker is 12 to 13 times higher. Just imagine that. For lung cancer mortality, the increased risk compared with non-smoker is 23 times higher in men and 25.7 higher in women. So moving forward, so we have here the tobacco use tool to assess readiness to quit smoking. We have the 5 A's. First, ask about tobacco use. Second, advise to quit through clear personalized messages. And then assess willingness to quit. And then number 4 is to assist to quit. Lastly, arrange, follow up, and support. Okay, these are the stages of change model. Of course, we have here the pre-contemplation, when the patient said, I don't want to quit. Contemplation, I am concerned but not ready to quit now. For preparation, example is, I am ready to quit. For an action, I just quit. And then maintenance, I quit 6 months ago. So you have also to check or encourage patient to have immunizations for adults, such as influenza vaccine and pneumococcal vaccine. So influenza vaccine helps in chronic conditions, immunosuppressed residents of nursing homes, healthcare personnel, and contacts and caregivers. So for pneumococcal vaccine, these are vital for all adults over age 65 because they are very high risk for having the pneumonia or infected with pneumonia. Chronic illness, cochlear implant, immunocompromised residents of nursing homes, and long-term facilities. Okay, so that ends our physical examination on the respiratory system, and these are the references. So finally, we're done. Okay, so but before we end this presentation, let me again share to you the Bible verse from Esther chapter 4 verse 14. Perhaps this is the moment for which you have been created. God bless everyone. Thank you so much.